button. That's great. So a very, very warm welcome to you all. It's really a delight to have Dr. Stephen Porges joining us this evening. So Stephen is a distinguished university scientist at Indiana University. He's also professor of psychiatry at the University of North Carolina and professor emeritus at the University of Illinois at Chicago and University of Maryland. He's the originator of the polyvagal theory, which emphasizes the importance of physiological states in the expression of behavioral, mental, physiological, and health, and also in relation to traumatic experiences. He's the author of numerous books on the subject, and it truly is our delight and honor to welcome Stephen into our meeting this evening. The evening is going to be hosted by myself, Michael Kern, the director at the Craniosacral Therapy Educational Trust, and also Giselle Geniard, of the director of SOS International, and also the organizer of somatic experiencing trainings in Europe. So I think just to start, I'm going to hand over to Giselle, who's going to kick off the meeting with an initial question for Dr. Porges.
Yes, Steve, it's truly lovely to have you in this chance for a conversation, because COVID certainly prevented some of those, but to pick up the conversations. I met you in Santa Fe all those many years ago, you know, yeah, BC, definitely. And instantly there was something about you that, as you were talking about your theory, just said coherence. And it also was perfectly germane to the model that I was learning somatic experiencing. But I'm aware that I might be interpreting it as we do the Gospels in my own way. And I think perhaps everyone, myself included, would love it if you could give your brief analysis of what is the polyvagal theory. You know, just whatever, 5-10 minutes. I know you could do 10 days, but
you know, well, first of all, Giselle, really, here's a hug to you and welcome. Thank you for being part of this. And I do remember meeting you and you driving me back to the hotel or someplace after the talk. And I was asking you specific questions about somatic experiencing and how it actually evolved as this very structured program from the very creative insights that Peter Levine had. And I was very interested in how one takes ideas and brings it into practice. So you're actually asking me a similar question. You're asking me, how does polyvagal theory relate to clinical practice, whatever your clinical practice is, or your own human experience? And I'm going to say, I'm going to start off with a very simple part of it, and that is how it rings true that the narrative of polyvagal theory is the narrative of being a human. So we start honoring our own experiences because we see them as being part of literally our inherited structure. It's not like we didn't do something, but our body has a toolkit, and the context or the situation triggered or repurposed the use of that toolkit. And in the world of trauma, we learn a couple of very important things. Is that the first thing is we try to create narratives to explain why something happened to us. And then we try to justify our reaction. So we end up with a lot of shame and blame and functionally anger at our own bodies. And polyvagal theory is a very optimistic viewpoint because it talks about how our nervous system reacts to try to preserve us. It leads us to strategies of survival. Now, those strategies of survival may often, I'm going to say may and often, do come with baggage. They come with things that interfere with our sense of our intellectual or our voluntary sense or of our own behavior. Because we, as a product of Western civilization, have this belief that if we're not in control, we have failed. And if our body takes over, we are truly failures, because the trajectory of our institutional education is to literally not listen to the body. Okay, so now you have a theory that says if you listen to the body, it optimizes your human experience. It makes you nicer and smarter and more adaptive. And the world we live in is a world that says don't listen to your body, do what someone else tells you to become successful, and not do what your body says to be successful. So you get into these conflict. So what is polyvagal theory? I would first start off with giving you a justification. The theory gives you a justification to listen to your body, to, in a sense, honor what your body is telling you. Now, that can sound esoteric or, in a sense, vague, but what it's really saying is that your body is always signaling you about what it's doing. So when our physiology supports homeostatic functions, health, growth, and restoration, we have the possibility of feeling safe and being accessible to others. So in a sense, those feelings of safety are not a option. They're really emergent of our physiological state. So when our body's doing what it's supposed to, we have a range of very positive experiences that we can have. So literally, feeling safe is our autonomic nervous system telling our conscious brain that it's doing its job. Now, when we don't feel safe, and this is now how we can now kind of like close our eyes and think about work environments, or my model has always been, what is it like to be a faculty member? Is it an experience of welcoming, accessibility, and safety, or is it an experience of chronic evaluation, which is another word for saying threat? And when you're under those states, your body is telling you that it's not comfortable, it's not supporting homeostasis. And our body, and in the world of body workers that we're talking to, what happens to the body when you're under threat? Well, we tighten up, we protect, we close the ventral side. And when we start talking about safety, the metaphor is the opening. And your Rolfing history tells you the same thing. It says that the chest opens up, the ribs move down. You can literally look at the rib cage to tell you what state the person is in. Well, polyvagal theory says you don't need to look at the rib cage or touch the person. Listen to their voice, look at their face. And it will tell you, because the body is now broadcasting its physiological state. Polyvagal theory gives the body a toolkit to broadcast its physiological state. So it broadcasts it through facial expressivity and intonation, because the calming vagus, the neuromammalian, the ventral vagus in the brainstem is connected with the nerves that regulate the face and head. So the way we even hold our head, the way our intonation, the prosody of our voice, and our ability literally to extract what people are saying is a function of our physiology being calm, but it's also bidirectional, so that when people talk to us in a calm voice, what happens? And we don't have to think of people, because if we thought about that, we might get anxious that someone is manipulating us. Think about how you talk to your babies or talk to your pets. Why would an adult human being talk with a baby type voice to a pet, to a dog or a cat? But we know that if our voice has this intonation, the dogs become accessible. So we know that through another social mammal, we can see the power of the systems that we have. And the dog may even go on the back and the mouth will open like it's laughing and giving its ventral side, not out of submission, but out of desire to be touched. And now we're going to flip into the body worker. What does polyvagal theory tell us, or tell body workers? That if you're going to touch people, they better be safe. Bottom line, that's it. How do you make people safe? Well, you have a toolkit. You can deal with the context. You can reduce certain acoustic features that trigger predator or defense responses. You can have a voice, a calming voice. You can even play calming music. You can make your context safe. And I call that a passive pathway, because body work is an active pathway of treatment, but it's predicated on the passive pathway being there, the person feeling safe in your presence. So polyvagal theory is this whole system that we have physiological states that not only evolve through different vertebrae, but we can see them developmentally when we study embryology. And of course, within craniosacral, embryology is part of what you learn about. So the more ancient autonomic areas, those that control that dorsal vagus, the one that causes shutdown, evolves before that social vagus evolves. So you can actually see it embryologically in paralleling evolution. So rather than, in a sense, live with ontogeny, recapitulates phylogeny, just be flexible and say, some of it does. And we don't even need phylogeny. We can just say, well, we know this ontogenic pattern. And when bodies get challenged, we go through what I call dissolution, which was evolution in reverse. But we can shift and say we just become more immature. We start using older structures. That's polyvagal theory. Polyvagal theory is that feeling or responding to cues of safety allows us to use the more mature structures of our brain that regulate our autonomic nervous system, while threat goes down to foundational survival, which is shared with very primitive vertebrates as well. And we move down that developmental, ontological, and phylogenetic scale. Polyvagal theory.
Mm-hmm. Thank you, Stephen. Thank you so much. Stephen, you said a few things there. One of the fundamental considerations is to generate a sense of safety. And then you went on to say how we use our voices, how we use facial expression. And of course, well, most of the people here attending this meeting are working in some kind of somatic field, including the body in their practice. And of course, we use voice, we use facial expression. When it comes to working with the body and when it comes to working somatically, what are the things that you feel we need to really remember here?
Okay, we have to remember that when people are unsure, meaning not feeling totally safe in the presence of another, they want to make sure they know where the therapist is physically relative to where they are, because the body is going to be detecting cues. So being frontal or being towards the client will help. In a psychotherapeutic one, at times, it doesn't work to keep people face-to-face because the cues of facial interaction can be triggers for people who carry trauma histories. So the part here is that the client in bodywork needs to know where the therapist is to start. Now, it doesn't mean you have to look directly in the face, but you can talk to them and tell them where you are. So the body of the client doesn't get into a hypervigilant state. Then the issue is what I call authenticity. Now, if we try to fake our voice, it's really may not work. So if we try to talk prosodic and we're not in a prosodic state, the safe state, it most likely won't work. So the issue is, can we, in a sense, create, I'm going to use a word I never used, so it's the first time on this podcast, is mindset. We create a mindset that we are accessible. So in a sense, visualize that we are a safe person and that we are accessible. What that means for the therapist is they have to give up their hypervigilance and really acknowledge that the client can't do damage to them by rejecting, by psychologically saying something, or even turning away from them. So the violation of our own social engagement, which is part of being a therapist, engaging, listening, talking, if it gets violated, our body treats that violation as a threat cue. So we start, oh, I don't like that person, or that person doesn't like me. And we create these complex narratives. And we don't, in a sense, give that person the narrative that that person is under a state of threat in the novelty of the environment. And we don't give the person credit for starting the journey of healing by coming into the clinic. So the issue is we have to have a flexible accessibility to the other person and realize, just like a parent, sometimes our kids may not treat us nicely. But if we're reasonable parents, we let that kind of roll off. And we often attribute it to the state that the child is in. They didn't eat well, they didn't sleep well, they had a bad experience at school or something like that, their state. When we get into adults, we tend not to respect the state the person is in, but that state is polyvagal theory. So we also have to acknowledge that the state that the therapist is in and the state that the client is in creates the dialectic, the interaction.
The connection there. So this is all about connection.
Yeah,
But
let me rephrase it a little bit. Yeah.
okay.
I was going to say that we use the word connection, and that is the product that we want. But it's all about signaling, and this is in polyvagal terminology, neuroception. There are signals that our body interprets as safety. There's signals that it interprets as threat. And we have to actually understand that language. Because if we don't understand that language, we'll create very complicated narratives that may have nothing to do with reality. Mm-hmm. So and again, I lean on my academic history, and I'm not leaning on the books. I'm leaning on my collegial interactions with colleagues. Frequently, colleagues in academic environments will walk right by you. Even when you may reach out to say hello, and you come back, especially as a junior faculty member, you say, oh, obviously I wasn't important in that person's life, which was probably true. But that's not the reason they didn't engage you. They were someplace else. They were not in a state of accessibility.
Why not?
Because we have to understand that accessibility is a diversion from other directives that that person's nervous system may be ruled by. Getting that grant in, finishing that paper, scoring those papers, meeting with the dean. These are directives that our nervous system is processing. And they're literally in a battle with this notion of being accessible and co-regulatory. So once we understand that there is this dialectic, we have to understand what our body needs to thrive and what our jobs need for us to survive. And you build a negotiation. And you say, I work hard, and we used to have this when I started, work hard, play hard, work hard, play hard. And then it was work harder for longer periods of time, play less, and then there was no play at all because the demands were so focused. But we have to understand that our nervous systems need periods of time not to be under states of threat, not to be evaluated, to be accepted for whatever we are. In a sense, we use terms like unconditional love, but we want friendships, we want trusting relationships that are not evaluative. And in a way, the client-therapist relationship has to have that component in it for the client to feel that they are welcomed in a non-evaluative state, and not that their progress is going to be evaluated. And medicine, of course, uses evaluation all the time because it's part of its billing model. So assessments become literally more important than treatments. And the issue is our bodies really don't like assessments. It's like standing in line looking to see what grade you got on the midterm. Or did you get the biopsy results back? It's the same type thing. Our bodies go into this fear response of lack of predictability. And what our nervous systems are saying, can we create predictability for short periods of time to allow our bodies to calm down? And that's what trusting relationships are about, predictability. It doesn't mean they have to be boring, but they have to be unconditional on some levels.
Which perhaps explains in this time of perhaps more uncertainty than many of us have experienced why there is so much mental health issues going on. But I want to ask you a question that's been plaguing me a little bit, and it may sound a bit counterintuitive given the me recognizing the primacy of safety. Can we, intervening with people, therapists, body workers, whatever else, keep people too safe? Can there be too much safety?
It's an interesting question. It's kind of like, so since we have our relationship, it's kind of like when someone asked me about appeasement, like I was telling you before we went on. I hadn't thought about it. Can we be too safe? I would reframe it as saying that too safe is really safe with not appropriate co-regulation. So that meaning that with co-regulation, there is functionally a neural responsibility of both people, that the cues have to be bidirectional. And if we're saying we're too safe, what we may be saying that is we're not getting reciprocity in our cueing. And this is important because in polyvagal theory, that co-regulation is a neural exercise. It's a neural exercise that facilitates connectedness and co-regulation and resilience. So there is no such thing as too safe. So we have to reframe it as saying that the narrative or the description of too safe for you is really non-contingent, more non-contingent connection.
Okay, that puts a different slant on it. Thank you. Thank you. I'm
Now you have to think for a few years on this.
I know. And having said that, just as you were talking earlier, I have to say, why weren't you doing this when I was 5? Why didn't you do this when I was young, before I took off and welfare and a midwife and all these things? How important? Anyway, I'm jumping in with my excitement, but you don't have to answer that right now.
Well, you could ask the same question to me. Why didn't I understand this when my kids were younger? Why didn't I understand this when I was my parents' child? Why didn't I understand this when I was navigating through elementary and primary schools? So the issue is, it's because what we were taught was based on principles that may not have been consistent with our neurophysiology. And remember, if we just even look at the school system, especially, many of the people there are products of the British boarding school model. I think Michael is, that but there's a whole history of lack of trust, lack of safety, lack of connection. But there's more of a history of shared trauma. So it becomes a totally different texture of the product. So the question on how we raise our children is a way in which we structure our society. If our society is about product orientation, is our society about relationships? Is our society about stuff, obtaining more stuff, acquisition of more resources, or about the benefits of interacting with others? So what are the transformative events that we want in or I should say, what does our nervous system prioritize? Interestingly, it prioritizes the interpersonal social ones over the stuff. But the society, in a sense, says, in many ways, minimize the body's need and optimize or maximize acquisition. The part that I've learned, I would say, and this is really within the last ability to conceptualize this within the past few years, is that sociality is functionally a neuromodulator, optimizing our health, growth, and homeostasis, health, growth, and restoration. Now, this doesn't fit well with the curriculum structures of schools. Think about that. So it would mean that more opportunities for social interaction would result in nervous systems that were more resilient and potentially could then be more accessible to learning. Yes. And that's my model of how education should evolve.
I think we're going to need to extend this for 2 weeks, Steve.
Oh, I wanted to mention something because you actually led in with in a sense, the contemporary times that we're all living with. And I want to basically emphasize that we've gone through, or still go through a period of a pandemic. And we have to, just like grief and trauma, we have to acknowledge what a pandemic does to our nervous system. It permeates it with cues of threat. It retunes us. We're different now than we were before. And so even though when you came online, Gazelle, you talked about the lusciousness of embracing others, I will tell you that, first of all, I view myself as a social person, loving hugs and engaging people. But I went to my first international conference this summer, and it was overwhelming for me. Overwhelming. My nervous system did not know what to make of it. Now, this intentionality was hugs, great, people, great. But the body was screaming at me to isolate, to spend more time away, in the room. And it was, to me, it was shocking. And then traveling in airports, I hadn't been in an airport in 2.5 years. It was overwhelming to me. It took me almost a week to recover from the trip to get home. So my body did not embrace it like the mind thought it would. The body's just not ready for this. Or let me use a polyvagal concept. I retuned my autonomic nervous system to be more prepared for threat than for accessibility.
Mm-hmm.
And I think that's kind of the message that we have here in terms of people who say, look, I know that I'm threat oriented, but I want my body to be accessible, and therefore I'm coming to you to help me on that journey. And I think polyvagal theory helps the body worker understand that their clients' bodies have a nervous system that's retuned to be defensive. And they have to, it's not, oh, relax. It doesn't work that way. The body has to become accessible. And the astute therapist sees it, sees the body opening up, or you have all kinds of words that you use, but the body basically becomes accessible, and you can touch people when their body is that way. And sometimes their body changes and doesn't need you to touch, because the body will reorganize itself in a more optimal way. And you have within the realm of craniosacral that full range of people who touch and who basically create proximity that's sufficient to signal the body to be safe.
Stephen, it's beautiful to listen to this. And you're saying that one of the fundamental things that we as practitioners need to consider is our own state of availability and presence.
Yeah.
And I'm curious if you have any thoughts or ideas for how do we hold that? How do we manage that, particularly at times like, you know, like you were saying, your experience at the conference where actually you were not feeling that, you were not in that, you know, your physiology.
First of all, let me give tremendous respect to the therapists who hold the space, who do that, and let them first understand that I don't do that. I mean, I talk, and talking is easy. So in a sense, I'm not absorbing a lot of the, let's say, trauma histories that you absorb when you interact with your clients. And the issue is, how do you not absorb it? How do you let it pass through? And we're going to go through some of that as well. The point we need to start off with is to honor our own body, meaning listen to what our body's telling us. So if a therapist feels they're overwhelmed, they're not going to give any gifts to their clients that day. It's just not going to be as an effective intervention or therapy. And often, not only do they feel in a good space and can work a lot with their clients, but their progress with their clients impacts on them, and they feel energetic from that interaction. And that's co-regulation. Co-regulation is a nutrient. It's just like interacting, it's socially interacting. It's a nutrient. And even during the pandemic, I talked about I need social nourishment because my body's changing and I don't want it to change. I want the social nourishment, but I think I went too long. But the work first point is that we have to be aware of our own state, and that requires self-awareness, self-care, self-compassion, all these self words that we push aside because we have a job to do. But we have to get back to that. And then we have certain toolkits. We have visualizations, we have breath work. I even, as a youngster, I would say real youngster, I'd say when I was younger, I used to use this term de-afferent, take away the sensory information. What I was really saying, I need a time and a space where I'm not reacting to the world around me so that my body can recover and re-equilibrate, in a way neutralized from the toxicity of the hyper aroused or hypersensitive or hyper-cued environment that I was living in.
So this is absolutely fundamental, isn't it, Stephen, that, you know, before we begin anything, you know, whatever skills, whatever techniques, whatever modalities we're using, we have to keep coming back to how are we in this situation?
Yeah, let me kind of step on that a moment and say that we need to understand that our treatments are not manualized. It may be manual, we may be using our hands, but they're not manualized treatments, they're interactive treatments. And the problem, again, this even occurs in psychotherapy models where people are basically taught that you do this, you do that, or the mixture, or going towards pharmacological treatments, that these are manualized ways of changing. And now the interest in neuromodulation, vagal nerve stimulators, and other things, misses the point. The point is that sociality, a way that we present and interact with others, is a very potent neuromodulator that calms the body and makes it accessible. So if there's something that is a take-home here, it has to do with that responsibility of being accessible to promote sociality and co-regulation in the client.
So the relationship is absolutely key. The foundation and the setting up of that therapeutic relationship.
Yeah, so I broke it down
key.
in some talks. I talked about an active and a passive pathway. And I think most therapeutic trainings focus solely on the active one. What is your toolkit? What is your manipulation? When you see a symptom, what do you do? Polyvagal theory says that's great, but if you want to be efficient, you have to have a physiological state of your client that's accessible. Can you utilize a passive pathway to give the body cues to turn off threat? Now, remember, lack of predictability is a threat. So like the first session, a person comes in not having any experience with a body worker, not knowing you, is potentially a threat to the client.
Yes.
Acknowledge that. Deal with giving cues of predictability, enabling the nervous system of the client to have a positive expectancy of an interaction in a context that's not distracting, that's comfortable and feels safe.
Right. Giselle, do you want to come in here? Your sound is off, Giselle.
Yeah. My brain was still struggling with my questions about too much safety, and that may be more specific to my own therapeutic approach. Ranges of resilience and stretching those, et cetera, and how we can.
Actually, we can go back to that because I have some other ideas.
You said cogitate, and as you were talking, that I was noticing that was coming up. It was weaving into other things, so I don't know if it's worth going back. But
it is, because I lived the life of believing that when people were in states of threat, or what I would call anxiety, I felt that I could take care of that by removing the apparent causes of that anxiety. And so in a sense, we can say that the pathology that I had was to think that being in a state of threat was caused, was outside the individual's body. And the point we want to emphasize is that it's inside that person's body. So the desire I had was to remove the cues or the triggers which I thought were causing the feelings of threat, so the person could be who I thought they could be. But that wasn't their journey. Their journey was utilizing cues of threat, basically to stay alive. And if you have trauma histories, people know that. They keep mobilized, they keep busy. So I didn't understand, and since I didn't understand polyvagal theory, because it didn't exist. And so I thought that when people were literally acting out their anxieties or threats, there was external reason for that. I didn't realize that the nervous system of that individual had to stay mobilized, because if it didn't, it would shut down because of something horrendous that occurred earlier in their history, an abusive experience. And we can see this in many people that we interact with, that the cues of safety are not good cues for them. And I will go to that, actually elaborate on that. So I developed an acoustic intervention called the Safe and Sound Protocol, with the expectation that you could have distilled, I would call it distilled essence of trust in an acoustic signal, just like a mother's lullaby, and that the body did not have an option, but had to become accessible. And it worked actually quite well with children on spectrum, individuals with auditory hypersensitivities. They kind of like became spontaneously social. Many of them, auditory hypersensitivities decreased, people, their autonomic vagal regulation increased. And so as I was giving talks through the world of trauma, the intervention became commercially available. So trauma therapists decide to try this. And what we started to learn is that the cues of safety became triggers of dysregulation for many people with severe trauma. And I can actually map this out for you. That let's assume that you're hypervigilant and it works for you. You're staying alive. You know, you may not be comfortable, but your body, in a sense, is safe by its chronic defenses. And you listen to this, and suddenly your body opens up. And there's this calmness going through your body. Now, that calmness has an interoceptive component, meaning your sensors within your body pick it up. And now those cues percolate up to your conscious brain. And your conscious brain says, vulnerability, getting the hell out of there. And I'll give you a real life example. In Poland, during this crisis with Ukraine, but several therapists wanted to use the safe and sound protocol with refugees and their children. And one therapist tried it with a woman, and she lasted 43 seconds listening to it before she pulled the headset out and had to get out of there. And the point is, if you come out of a war zone, do you want to be accessible? I wouldn't say, do you want to be? Can you be accessible? Your body is retuned. It takes time to re-educate that nervous system to give up the defenses. And this is what the trauma therapists learned about the safe and sound protocol. It was very helpful in treating trauma, but it had to be titrated very slowly, very similar to somatic experiencing strategies. And it could be intertwined with somatic experiencing, EMDR, and other therapies, because what it was doing was giving accessibility and feedback. So you could have down this discussion with the client about how do they feel? What were these bodily cues? So it's not about the traumatic event. It's about those bodily feelings. And the therapeutic strategy or goal is that you have bodily feelings that don't carry with them the strong association with the injury.
So I'm wondering how, because even though I spent 25 years daily with my hands on people as a role for craniosacral, the last 20-something years, I haven't done, but for those people who are primarily using touch as their primary tool, how are you transferring that into that context? How could you suggest that they use the polyvagal theory?
Well, it's really knowing, it's not using touch, it's knowing when to use touch.
Okay.
And I think most somatic-oriented therapists know that. They're aware of when touching someone is accessible to the client, and when touching someone triggers a defense. And it can even be a dialogue they have with the client. So, you know, again, let's go back and talk about the dog that goes on its back and says, rub my belly. In a way, that's what you're trying to do with your clients, because the ventral side of the body is the side we're going to protect.
Yeah.
And what you want to know really is how defensive is the ventral side. And so it may start with hands, maybe that's okay, limbs. But as you start, or neck, the interesting part is if you can get onto the neck and the face, you're already manipulating that vagal circuit because of the afferents of that. So you can get portals into calming the body without touching the ventral side. You can work on the face and head. And there are, of course, methods like that. There was Alexander technique and Feldenkrais, and, you know, varieties, things, which in a way were strategies to manipulate the sensory part of cranial nerves that impacted on autonomic state. So there are different ways we can do things. Breath work can be helpful, because when we take deep breaths and exhale slowly, the vagal effect is calming. If we take long inhalations, we tense our bodies up. Or if we hyperventilate, we're off the table. So, I mean, there are things or cues that we can see that calming, rhythmic breathing, slow breathing, softening of the face. This is what therapists see. Maybe even like facial massage might be a first entry point to making the person calm.
Well, I would love to pass over to Michael for a question, because how that would apply, particularly because I imagine there are a large amount of people whose craniosacral therapy is their primary modality. Michael, do you have questions for Stephen on the application in your
Well,
Right.
I'd like to weave a question in, if I can, on this, with something that has always really touched me around polyvagal perspective, and that is the understanding of, and I can't think of a better word, but of the hierarchical function that is present within our autonomic nervous systems. That if we can bring people back into social engagement, that this somehow, we could say, downregulates the sympathetic activation and also the parasympathetic reactivity or shock that might be present. And I just wonder, Stephen, for people who are not necessarily using talk as a primary therapeutic tool, although of course we're all using talk and we're all using voice and facial expression, but I wonder if you could speak a little bit about this kind of hierarchical function that's present within our autonomics.
Yeah, that's why I introduced this concept of sociality as a neuromodulator. It's a neuromodulator of this neurovagal circuit, which is linked to the regulation of striated muscles of the face and head. So even though those muscles and nerves are not regulated by the vagus, they affect the vagus. The vagus affects as part of an integrated interneuronal communication system. That gives us various portals of stimulating that neurovagal circuit. But the construct that you are really reaching for is what I call the ventral vagus as being a choreographer or a cheerleader, constraining and exploiting literally the sympathetic and the dorsal vagus, using it for the best that we are. So when we have social engagement, like I'm looking at you and we're playing a sport, we can be mobilized using the sympathetics, and it's fun, it's play. But if I don't maintain facial contact with you, my body has literally the potential of moving into aggression. And this happens with kids who don't play well on the playground, that someone hits them and walks away, as opposed to someone hits them and says, oh, I'm sorry, or that's part of the game, And we see that. And then when we watch dogs play, they tell us the story. They chase each other. They grasp the rear leg of the dog they catch, but the dog caught looks back, makes eye-to-eye contact with the dog that caught him to make sure this is not aggression. Gets reassurance that's playing. Know what they do? They roll reverse. So the dog that was caught now chases the other dog. And they have these games, and children have these games, and they're utilizing social engagement to keep the sympathetics constrained. Now, the other part is we can use the dorsal vagus to be calm with the social engagement system. That's what moments of intimacy are about. We use voice, we use cues, and the body feels accessible and doesn't respond. And the issue is if we touch those same areas of the body without the social engagement being used in first place, then we get defensive reactions. We get pain, we get, a bodily, let's say, defecation or passing out. But in a sense, if we operationalize them as being the same with or without the social engagement constraining them, we miss the point. So the point is that the social engagement system keeps the body, quote, homeostatic in safe states and allows these other attributes of a sympathetic nervous system and a dorsal vagal circuit to be helpful in our life experiences.
So if we can bring people back to back into a relationship or back into a state of social engagement, the rest is kind of taking care of itself.
It's kind of an interesting story because we're finding, there's a paper, I'll share it with you so you can share it with the people who signed up. It was a clinical case studied published in the Harvard Review of Psychiatry of a child with functional neurological disorders. Now, what does that mean? It means a lot of problems, but they can't identify the causes. And she was in a wheelchair, she had gut problems, she had chronic pain. It was not a good story. She had anxiety, she had depression, she had all these mental health issues. They tried everything because this was a mind-body center in a department of psychiatry at the University of Sydney. And what they ended up doing was using the Safe and Sound protocol. And within a few weeks, she was back in school, out of the wheelchair. So in a sense, there was a retuning of autonomic functions because the intervention triggered in her nervous system that she was safe enough to recruit these structures. And that's the point I'm making, that a lot of functional disorders, and many people coming to craniosacral therapists have functional disorders. What does that mean? It means that their physicians can identify a cause. The end organ is not diseased. But that's just because medicine doesn't have a measure of neuroregulation of end organs. Polyvagal theory says neuroregulation precedes end organ damage. And so the functional disorders, hypothetically, using a polyvagal perspective, is a dysregulation of autonomic function, which will give you these symptoms. So I think we can see that if the body gets cues of safety, the nervous system comes back into play, the autonomics, to telling the body what it can do or enabling it to do what it's supposed to do. And we can give that literally a global term. We call it homeostasis or homeostatic functions. So we become healthy. And polyvagal theory extends the role of homeostasis, not just from health, growth, and restoration, but also sociality. And sociality becomes bidirectional, because not only is it a product of homeostasis or feeling safe, but it contributes to it.
As therapists, midwives, facilitators, or whatever it is that we call ourselves, we're using our connection to support neuroregulation in another. Yeah, basically, love this about connection. But I'm curious about what really is connection. What are we connecting to? What is this thing?
Okay, so yeah, what are we connecting? We are creating a symmetrical, reciprocal, and synchronous reading of cues from each other. And we can tell that if we don't have the cues, so like texting doesn't work the same as a dialogue. Zoom isn't bad, but it's not the same as having coffee or lunch or dinner. It doesn't have the same sense of accessibility, but it's not bad. Let's not say it's bad. It's certainly better than talking on the phone. On the phone, all we're depending on or using is intonation of voice. But with Zoom, we're getting facial expressivity, a little bit of gestures, a little bit of dismissal. We get all the things. We can read the cues. The part of connection to me is it's about the ability to regulate each other's state. So connection is, I'm regulating your state, you're regulating my state. Now, if your attempt to regulate mine or your behaviors don't calm me down, but kind of tick me off, we're not connected. But if I am, okay, let me give other examples. We all have engaged people in our lives that we don't like anything that they talk about, but we like them. Have we ever had that?
Mm-hmm.
And they've had kind of what we would call a charming temperament. Their voice was melodic. They made us feel safe in their presence. But we didn't like their politics. We didn't like their positions on anything, but we liked them. That tells you a lot about what connection is about. It's about our bodies feeling safe enough with another person. And what is that? It means that there are certain cues that literally efficiently disarm us, make us accessible.
Does that not butt a little bit against what we were talking about earlier about authenticity and the ability to detect beneath the apparent signals that there is something dissonant?
Okay, okay, this is an interesting question, because my first knee-jerk reaction to that is really what do we mean by authenticity? And I was gravitating on the authenticity is a body definition. You were gravitating that it's more than a body. It's also contextual and it has a language to it. And I'm willing to give up that part. I'm willing to give up the language and saying, and look, we can love our dogs, we can love our cats, because of how we feel in their proximity. And we're not evaluating what they're saying to us. We're not evaluating the cat culture or the dog culture. We're evaluating what cues they're sending to us. And we share a lot of that with mammals. So we have this capacity to connect, not through our language, which we think is our total way of communicating, but through, let's say, vocalizations, meaning intonation of voice, gesture, how we hold our body, which is deep within a lot of the somatic therapies. How we hold our body is how we are projecting our physiology, because when people are tightly wrapped, their bodies are in a state of threat. When their bodies are too loose, we're not interested either. But when the body does, quote, what it's supposed to do, have a reasonable muscle tone and have accessibility in its presence, and it's supported by intonation and gesture, we're fine. We don't need the language. The language can give us problems. So there are people who feel very comfortable with some people as long as they don't talk. It's
prolonged.
And we need to not necessarily gravitate to people like that, but we need to understand why, as a human, we feel that way. And that will give us guidelines in how we create or allow ourselves to create certain relationships. Because in the latter, in the one that we really don't like the politics or the positions or the intellectual part of that person, our bodies can get bonded, and we can be in social relationships that don't work, but our bodies feel safe within them. So it creates this conflict that makes it very difficult in the world we live in. But in a different world, like stranded on an island, we might be fine.
Stephen, can you say anything about the safe and sound protocol? Are you able to just give us a summary of what?
Yeah. Okay. So the safe and sound protocol, as I said, was designed to be a stealth method to functionally trigger the nervous system into being an autonomic state that supported safety. And it worked well, extraordinarily well, with younger children. And again, I said, was triggering different type of responses in those who have trauma histories. But what it does is it uses an acoustic pathway. We can think of it that way. So we talked about facial expressivity, intonation. How does the voice calm your dog down or your baby? It's using an acoustic pathway that is wired to the ventral vagal circuit. It calms our bodies. And this goes back to the notion of that circuit constraining sympathetics. So the crying baby calms down. It's not by what you're saying, it's the intonation of your voice. And we just published a study a few months ago using a tronic still face procedure where the mother freezes her face and the baby just gets destabilized. And we looked at the baby's heart rate and the mother's intonation of voice following the still face. If the mother's voice was prosodic, had a lot of intonation, the baby's heart rate went down and the behaviors calmed down significantly. If the mother's voice lacked prosody, the baby's heart rate didn't go down and the behaviors didn't calm down. So the point is, we can see in a pre-verbal infant how the intonation of vocalizations can send a signal of safety. Now, that was the principle of the safe and sound protocol. It was to amplify the prosodic changes. So it was more than the prosodic mother, it was a hyperprosodic modulation of sounds. So I designed it so that I thought the nervous system had no choice but to respond. It had no choice. And because of that, I viewed it as a stealth, a way of intervening, of making the individual accessible. And it works extraordinarily well, with the caveat that if you carry with you an adversity history, that feelings of accessibility can trigger a feeling of vulnerability. But it was the game plan for me was that I saw it as an acoustic pathway of vagal stimulation. So rather than, on the neck or surgery or on the ear now, you listen and suddenly you calm down. And I use it that way. So I use it to calm down, and it's quite effective in terms of how it's being used. There are now over 3,000 therapists have been trained in it, and it's quite remarkable. I mean, and Michael, you heard me talk about the idea of this years ago, and the fact that it's been commercial for like 3 or 4 years, and there are 3,000 people using it, to me is really a remarkable and a feeling of both gratitude and self-validation, because the people using it are very committed to what they're doing. And actually, there are a couple online. I saw the faces on there. And the point is, they're using it for a variety of things. In fact, there are body workers using it for like 5 minutes before they do their session with their clients to create literally a state of relationship even with their client that makes the client more accessible to be touched. So there's a synergy between that and body work or body psychotherapies. And I was saying that there are over 200 somatic experiencing practitioners using it, and I think the number with EMDR is approaching that as well. So it's not a therapy unto itself, but when it starts getting intertwined with others, you can see it more like that passive pathway, and EMDR and somatic experience, it becomes the active pathway, and craniosacral would be an active pathway, which might be facilitated with the Safe and Sound protocol. I will make a statement that we are having our first face-to-face live Polyvagal Institute meeting. It's a 2-day with Polyvagal Institute and 2-day with Unite, the company that distributes the Safe and Sound protocol, in my hometown, Atlantic Beach, Florida, in the second week of October. And actually, there's Michael's on there, Michael Allison, who's going to be on the program. So he's there. I can see him. Thanks for sending the signal up. I could see that. But the point is that we're learning. And I wanted to actually talk about a population for a moment, that a couple of, first of all, there are therapists using it with long COVID, and that's interesting in itself, because long COVID, like chronic pain, and there are others using in chronic pain, are medical conditions in which the actual, with chronic pain, the damage has been healed. With long COVID, the pathogen has been killed. So the body is literally stuck in a defensive mode, and those are the symptoms. Now, does the Safe and Sound protocol help the body get back to states of safety or social engagement? And the answer, it contributes to it. It's not a on-off switch that you can listen for 20 minutes and it's all over, but it's been helpful. So that part is of interest. Oh, I want to talk about Parkinson's. And I think there are going to be people online in craniosacral who work with Parkinson's patients. And there are a couple pilot projects going on with Parkinson's patients. And what has been interesting with the Parkinson's patient is that the social engagement system literally comes back on board. The face becomes animated. Voice gets intonation almost immediately. But that's not necessarily good, because the body reacts to that with tremendous sympathetic reactivity. So that ability to, so to speak that way, the sympathetic nervous system tries to pull it back to where the Parkinson's has brought it. And so you start seeing in some of these therapeutic applications very slow titration, and I'm meaning like only a couple of minutes a day, where the body starts to enable itself to accept being social engagement being on without triggering that sympathetic nervous system to literally, it's like a warfare, recoup its lost territory. So in a sense, the body starts to strain up, then the sympathetics come in and you get the pulling over the sympathetic activity. There's a lot we can learn from how our bodies react to cues of safety and when they are literally problematic. So where safety is no longer what our body can tolerate.
Stephen, I have another question. You place a great emphasis on the functioning of the vagal system and the cranial nerves as being the primary modulators of social engagement. Is that all there is to it? Are there other aspects of our physiology?
Okay.
Are there
So,
other aspects of our nervous system?
yeah, well, of course there are, but
also
let's
responsible?
define what okay, so we're going now, what I call the social engagement system is a easy term for the functions, as I see them, of the structures that are regulated by the special visceral efferent pathways. These are pathways that evolved from 5 cranial nerves to regulate the structures that evolved from the ancient gill arches, the face and head. Okay, so they have a anatomical definition. Now, and they start off in our lives as our sucking, swallowing, breathing, vocalizing circuit. And they evolve into our social, facial cueing, ingesting, listening, head tilting, circuit that we use for socialization. They are not the only parts of social engagement. It has to do with what are the functions of this. Now, in the world that all of us are living in, we can see that eating disorders become part of the selective eating disorders. The ingestive circuit hasn't lost its power as a calming mechanism, and we realize that eating disorders are valiant attempts to calm our body through ingestion, but that's not as efficient as social behavior, sociality. But the people who have eating disorders don't often have access to sociality as a calmer, so sociality may be a trigger for them. So we can see that through our lives, ingestive behaviors are associated with sociality. We go out for lunch, we go out for dinner, we have a drink together. That's the same ventral vagus is involved in that ingestion and social behavior. But if we move over to digestion, the other part of this system, which is related to that dorsal vagus, that's privacy in safe context, because we interfere with that when we are mobilized, we get constipation, and threat affects it, we get diarrhea or gut problems like children have at school. So we can see that that ingestive circuit is really develops into a more integrated social circuit. But it's not the only. So like there are people who will say, well, Porges missed it because he didn't include the tongue. So fine, the tongue's great. That's not the issue. The issue is the tongue's not regulated by special visceral efferent pathways. It's this package together of special visceral efferent that enable the use of the sensory aspects of those cranial nerves to trigger the ventral vagus. And in fact, the non-invasive vagal nerve stimulators going on the ear are using that model. They're saying if I can trigger on the facial nerve, the trigeminal nerve, excuse me, the facial trigeminal nerve, or the vagus nerve, I can calm the body. So there's a stimulator that goes on the forehead called Monarch. It works very much like a vagal nerve stimulator, but it's stimulating the trigeminal. If you go on the ear, you can affect, as I said, 3 different cranial nerves are there, and they can all impact on that whole circuit and calm us down. So the point is, the emphasis on those 5 cranial nerves gives us interneuronal connections among them that enable us to give us a variety of portals to get our bodies calm. And that was the whole idea of social engagement system and sociality as a neuromodulator. I'm not saying that there aren't other pathways involved in it. So it wasn't a gotcha moment, Michael.
Thank you. Thank you. Giselle, is there anything you'd like to come in with?
What next, Steve? Where could this go?
Well, I think let's go where body workers want to go. I think the polyvagal theory to a body worker is really about how does the body of your client become accessible to the work you want to do. And I guess we start with asking, going through an introspective question, that when a body is defensive, how effective are treatments?
Mhm.
Or delivery of treatment?
Beautiful. And perhaps I didn't phrase my question quite articulately enough to say that in my journeys in different contexts, when I'm taking SE out into the world, sees me in a variety of different contexts, and everyone knows about you. Not because I'm talking about, because they do, because it's so relevant to the context I work in trauma that I'm working in. And I'm just thinking, so where would you like to see this work being landed? Body workers we have here, we have body workers, we have somatic workers, all across the therapeutic domain, but stretching beyond.
Okay, that is a great question. And I would start with, there are two areas that I think are quite relevant that I'm interested in impacting on. One is how medicine is practiced.
Is what?
So medicine is practiced. So again, and I guess the metaphor is, can medicine recruit the nervous system of patients as a collaborator in a journey of health and wellness? Or is medicine frightening its patients and making them less accessible to treatment? And the answer. The answer is that medicine is an evaluative discipline, and people are frightened of it. And by being frightened, it interferes with the effectiveness of the treatments. But medicine also has taken a very deterministic, mechanistic viewpoint that doesn't allow the internal attributes of the body to mediate the effectiveness of treatments. So that's what clinical trials are all about. It's about neglecting or not being concerned about individual differences. And the individual differences in the polyvagal theory is the autonomic state, and that's this mediator of whether treatments, including medical treatments, are effective. That's my perspective. So the idea was, can we change the culture of how medicine is delivered to change the state of patients so that the patient's nervous system is working in the same direction as we hope the treatment is? And within the Polyvagal Institute, we are starting that. We actually got a contract or a grant from a company that has many clinics. And so we are trying to change the culture in a couple of them as a feasibility study. The other one is education. So we have, in education, we have the same issue going on, and that is it's chronic fear. And it's justified. Fear motivates. Well, the issue is fear does motivate, but it motivates fight, flight, mobilization, immobilization defenses. It doesn't motivate intellectual problem solving because the body, the nervous system, shifts out of accessibility to these higher brain structures for complex problem solving. So it doesn't work. So the notion is, can you change the culture of education to enable more social interaction, more co-regulation, as a way of building resilience in the nervous system that would enable children to sit longer in classrooms and process information, as opposed to taking out of the curriculum all those social interaction opportunities. So those two areas. Then the other one, of course, which is, we can just mention briefly, is social justice. We create a culture of fear, and the consequences of fear just create defensiveness, and defensiveness can lead to greater aggression or greater withdrawal, or let's say lack of participation. So we, in a sense, are, through the way that we treat our fellow humans, we limit their opportunities to be who they really are. When I say be who you really are, is really when our bodies are in homeostatic safe states, who are we? When we feel safe and our body doesn't support. And of course, we have all the information. We know that it's not just social justice, it's marginalization of minority groups or groups on a whole variety of dimensions. And we know that they suffer in terms of health vulnerabilities. And we know that even during the pandemic, we have good indicators of the same thing. What we have found through our own research during the pandemic is that it's not just adversity history that led to the vulnerability of mental health disorders during the pandemic, which it did. But whether that adversity history retuned the autonomic nervous system into a state of more threat. So virtually all the variants of adversity history was covered by a subjective measure of autonomic regulation. So if our autonomic nervous system is retuned, repurposed for defense, guess what? Put another threat into our nervous system, we have mental challenges during the pandemic. Now, the interesting part was we did this study during spring of 2020 when the first wave of the pandemic occurred. And we had about 2,000 participants, 100 had gotten COVID. The interesting part was, number one, if you looked at adversity history, on that 100, a group of 100 who had the disease, virtually none of them had adversity histories, low adversity histories. So not only were they less affected, they were literally immune if they didn't have an adversity history in the first wave. Now, remember, variants find their way into our systems. Now, if you moved up in that study and said, look, you have a high adversity index, virtually, I would say, not everyone, our regression line said over 75% got COVID. And that's a significant risk. The interesting point is that, and I was very cautious on interpreting this, is that the curve for autonomic reactivity was really accounting for that adversity. However, even though we didn't know whether the self-report autonomic reactivity was contemporary or the past. And the model was that was that the autonomic nervous system got retuned by the adversity history, not by the pandemic. And so the point that I take home from those who got the disease is that adversity history is a powerful retuner of the autonomic nervous system, and adversity history is a pre-existing condition. And I think that is really what we learned about, that our trauma history is a pre-existing condition. It's a retuning. And without a medical community and a society that is aware of autonomic state as being a major mediator of how we relate to the world, we're not going to get very far.
Well, I hope you have a patent on your theory for the next pandemic, because that would be a great.
No, you see, that goes into this notion of why are we doing things in life? So the issue is we can do interesting things in life once we have enough, meaning that we're safe enough. When we're safe enough, then the creativity moves out from our own needs to others, to connection. So the point for me is and that's why we created Polyvagal Institute, was the notion of dissemination of ideas. Let others grow with these ideas and not ownership. But thank you for suggesting that.
So connection, Stephen, is primary, and everything else is just an overlay.
Yeah, that's an interesting way of phrasing it, Michael, because what we're saying is the connection, or the co-regulation with the person, is primary, and our narratives use the overlay. And this is an interesting issue, because when I was doing work with autistic children, or let's say in my life when I talk to parents, let's not say I was working with autistic kids, when I talk to parents and they say, my kid was very smart, I ask them, I say, okay, what's the problem? Because their initial description of their child has to do with productivity or intelligence, not on a loving or a liking. And it's very interesting to use that and say, okay, tell me more about your child. Does he or she have relationships? What do you like about your child? As opposed to the child being defined by test scores. And remember, the world we're in is so evaluative that we think that those test scores are primary. They're important. And an example, I was giving I was at an international conference, and one of the presenters came up to me and said she wanted to talk about her daughter. I said, tell me about your daughter. She said she was born at 25 weeks preterm. She was 25 weeks when she gestationally born, very preterm. And I said, how is she doing? She said she's doing, great. She does well in school. I then asked the real question. I said, tell me about relationships. She said, clueless. And so you get the issue of how our society has focused. Yes, we've maintained better success with preterm babies. They're doing well cognitively, but we haven't really intervened in facilitating the neural regulation, the neural exercises to get their autonomic nervous system back on board to be flexible in society. And that's really what happens with preterms. They are pushed into a world that they're not ready for, and the body literally gets stuck in more of a defensive autonomic state. And that's actually some of my own research on preterm babies. So
interesting. I didn't know that.
We've got a number of people have got their hands up. There's also been various questions that have come in the box. We probably have about 10 more minutes. I'm just wondering of the best way to go about this. I mean, a few people have written questions. We could just kind of read them out, or well, would you like to have
let's do the first three quickly, and then let's go to the reading, because their hands are up. I could see faces. They put themselves out there. So
we can take a question, yes, or comment. Yeah. So perhaps Natasha, if you'd like to come on, and I know you wrote a question quite early on. Perhaps you can unmute yourself and come online.
Thank you. So thank you very much, Stephen, for your webinar. It was just like an explosion of connecting things in my practice, and really, really appreciate what you're doing for the whole world, really. My question was specifically around attachment theory. Since this is about our primary caregivers, healthy, safe way, for many people in the world, like myself, who's a recovering and fearful avoidant, how could those of us who are still working on creating a secure attachment to ourselves and in relation with others, how could we use the polyvagal theory to help us on our journey?
Yeah, the first point is that helping you is really to start learning how to respect your own body's reactions. So in the way you're presenting it as if there are limitations in your life experiences because of your history. And I don't want to be pushed to anything, but I'm saying you could reframe your narrative in a very positive way of survival, of heroic survival, and take a couple of breaths on this as feeling proud of how your body enabled you to survive difficult situations, and then think about the physiological experiences that you have when you take that positive viewpoint, so that as we literally honor ourselves, our body listens. And that's really what I'm saying. Let your body feel honored, and let your body feel proud, or you feel proud of what your body did for you, your nervous system, in helping you navigate different parts of your life. I think that helps us a lot. And the other part is that polyvagal theory fits into attachment theory. I actually wrote a paper on this for an edited book on attachment, that I talked about social engagement system as a preamble for attachment. So that if we watch how relationships are created, if we're young infants, we see that it's a bidirectionality with the parents and the child. And this is why the preterm kids have a great challenge, because their face doesn't work. It's not the neural regulation is not developed. So the parents lose the feedback, and literally the parents will make statements like, I love my child, but I'm not sure that my child loves me. The same statements that an autistic parent will make, because they're not getting the reciprocal cues that their nervous system is demanding. So I think in understanding the compromises or the challenges to your own nervous system, you start building a different narrative that will be helpful.
Thank you, Stephen. Michael, would you like to unmute?
Hi, Steve. It's great to see
Hi,
you.
Mike.
I just wanted to emphasize a couple things that I thought would be really relevant for all of us. And one of the things that you said is the body prepared for threat or prepared for safety. And for a lot of the people that we're seeing in this sort of work, they're coming in prepared for threat. And so I just wanted to emphasize that because I thought that was really well put. And then that leads to us then putting aside our agenda and instead shifting it into how can we help them feel accessible? Because you also emphasize that accessibility is in the body. So I just wanted to emphasize those points. And then there was one last point that I thought was really brilliant, is putting aside evaluation of progress. And if we instead look at progress as simply, are they beginning to feel accessible? Are they beginning to allow some connection in their body? And that's a different kind of progress. So I thought those things were just really beautifully put that you said. I just wanted to emphasize. Thanks.
Thank you, Michael. Good to see you again.
Good to see you.
Thank you. Andromeda, would you like to say something?
Hello, good evening. Thank you, Stephen, for this evening. I'm a body-mind centering teacher, and with the work of Bonnie Bainbridge-Cohen, we speak immediately of safety, bonding, comfort to enable curiosity. And with other body-mind centering teachers, we are working with your work, and we are beginning to work specifically with hands-on. And I can't say we're choreographing something, but we're working with a way of hands-on to enable the vagus. As much as you have created this safe and sound protocol, do you have a hands-on protocol that you're working with, or I don't know, improvising, creating something?
You bring up an interesting question. The answer is no, but I'm encouraging to have a movement integrated safe and sound program, and I'm working with the company that's distributing the safe and sound protocol, because I think for some people, moving will keep them from the threat reactions of feeling safe. As long as they're kind of upright, the body's already started its mobility and can have greater flexibility. So not touch, but movement is where I'm going with that.
Thank you.
Thank you.
And just because of time, I think maybe this is going to be our last question. And that is with Catherine, if you would like to unmute and come online.
Great, thank you very much. This has been really, really helpful, Stephen, and really appreciate the focus on body and touch. As a body worker, I work a lot to create safety through touch and connection. And my question is really, is it important when someone has done a lot of internal deep work and feels safe with touch to have a moment or some kind of social engagement, which includes the face and orienting, as a way to kind of complete and integrate the work?
Okay, so it's also, all these questions become interesting. So I would say that if you did the deep work and the body was safe, the client would spontaneously engage you. And is really, your part is to be reciprocal, not to, in a sense, manipulate the client. So there's certain things that may spontaneously emerge, and that is when clients engage their therapist, when they lean forward or when they become, their voices change and their muscle tone change. You will see these things, and whether they're, in a sense, in a way, reaching out in a psychological space to connect.
So you're saying that to be available for that.
I think the primary point, it's almost like, what is the test that your work worked?
Yeah.
It's whether or not the client spontaneously engaged you. And of course, I think I'm sure it's happened several times in your career. And I'm sure when you had that experience, you said to yourself, job well done. And in a way, that's what I'm saying. I'm saying it's the availability, it's the support and the presence. It's not, that is, again, it's a passive pathway. It's not an active one. It's a facilitator or enabling the other.
Okay, thank you.
You're welcome.
Stephen, do you think we can take one more? We've got another hand up. I don't know where.
Yeah, we can handle.
Well,
Sure,
on
we
the
can
edge
handle
here of our time together, but maybe we can take a few minutes.
Yeah.
Okay, great. Aruna, would you like to come on?
Hi, thank you. Are you able to hear me?
Yes, I can.
Okay. I just have two questions. I'm a CST practitioner, and I enjoy being by myself more and meditate, and social interactions and all I do very less. And I just want to understand what it means in the context of polyvagal theory.
Oh,
And second
yeah.
question.
Oh, let's do one at a time first. Okay. The first one is there are great individual differences in our need to interact with others. So polyvagal theory is just saying you're expressing an individual difference. There's nothing wrong. There's not, this is part of the distribution of how people work. It's not like you are asocial. You just like time with yourself, and when you want time with people, you're with people. So it's not like there's anything atypical. It's just on a distribution. So it's not, polyvagal theory doesn't mean you should be social 24 hours of the day. It just means that you have the capacity to be social, and being social is not a neurophysiological threat to your system. It's nourishing. It's nourishing. Okay.
And the second question is, by profession, I also work for an IT firm. And so I work for a corporate where there is a continuous evaluation judgment. There is a lot of numbers driven by peer. So I felt when I heard about the polyvagal theory in my CST, and I read your work, watched your interviews, there is a lot of scope to apply. I just want to know if there is any book or article you would suggest which I could refer.
Yeah, and actually, well, I would say there's an article in Frontiers, which is open access, called Polyvagal Theory: A Science of Safety. I would look at that. It's quite recent. It just was published a couple of months ago. And so that would be a good start, because it really tells you what your nervous system is looking for, and it can be within any work environment or context. So it gives a different story to the world of stress. So we talk about stress, and what it says is we shouldn't even use that word. We should use the word that we have interfered with our homeostatic processes, and that changes our whole perspective of what our bodies need. And when we support our homeostatic functions, feeling safe is the emergent property. And work environments should have an understanding of that as well. They don't, but I should say they don't. Some will.
Thank you so much.
You're welcome.
Well, thank you. Giselle, would you like to say anything in conclusion, summary, or final question?
Oh, no, I don't think. I mean, I know that there are many questions. I'm sure everyone would have a question in this group. But I just wanted to honor Steve, because I think perhaps you don't know that this, your polyvagal theory is extending beyond. I mean, it is in Europe, which I'm beginning to know better now, in the National Health Service. I just worked in a psychiatric hospital within the prison service last week for 2 days, and they really know and honor you. So all I could do was to lean into that with the skills of SE. And so I would like you to know that. And even now in our much thoughted, I don't know England so well, parliamentary system, people are beginning, this is threading through. I don't know from an American perspective, because I left America in 2012, but it is going. And I know that Google is holding, influences this too. So I just wanted to, this is what I was saying. Do you know this is getting out because we can experience it to be so? And I just want to thank you very, very much.
Well, thanks. We all have different, as I said, goals in life, and the interesting part, I will really say for me, is I see ideas as coming through me. I see them as my job has been a translator or a messenger. I don't even see myself as a creator. It just seemed, when I even came up with the theory, I felt it was derivative. It was obvious when I read the literature. And it's been like, 25 years, 28 years. And to me, if anything is shocking to me, it's the fact that many people fail to understand the continuity of it with the history of science, the history of our knowledge of the body. And because the narrative is a beautiful narrative that comes from it, of our evolutionary journey. It's a beautiful one of leading to sociality, of caring and connection with others. And I think that's, so when we acknowledge that as our true heritage, life on the planet changes. I want to mention a couple of other things, that in prison work, there are groups I know in Ireland who are working with polyvagal theory in prisons. And my son, Seth, who is a journalist by training and then is a movie maker as well, has just finished with me a book on polyvagal theory that is written in a voice that should be accessible. So it's actually, the final draft has been done, and we've been going back and forth on things, so it should be out within a year. So I'm excited on that. And the other thing is that we're writing a book on the Safe and Sound protocol, and that will be that we're signing a contract on that soon. Not set. This is with another person who came out of the company distributing. Her name is Karen Undecker, a remarkable woman who I viewed her as, let's say, the guardian of the Safe and Sound protocol. And so we're writing a book together, and it's going to have a lot of stories, clinical stories of change. And then I will be doing a deconstruction of what those changes, the underlying neurophysiology of that, what I can do. I'm a deconstructor. But Gazelle, the issue of credit is, I would say, that bus left the station. It's lovely to hear, but it's functionally, to me, and I don't mean to be dismissive, it's functionally irrelevant. The goal is for ideas to be understood and embedded in how people live their lives. And the issue is, and this is part of what is authenticity and accessibility. If you are focused on your own self needs, whether we call it being seen, being heard, acquiring more material, you kill the message. And at least you kill the message of polyvagal theory. So I want to be true to what the message is. That has been my goal. It's come through my body over decades. Long before the theory came, I was ruminating on these ideas. I just didn't have a language for it. I struggled for a language that would be understandable. I'm still modifying it to make it more understandable. But I think it is our heritage, and we are entitled to know about who we are, and to use that to optimize the experience of being a human. It doesn't make us anything different than what we are, but it enables us to know who we are.
Your lack of ego and your humility make you, for me, truly masterful, the way that you represent your model. And I want to thank you out loud. And you can reject it if you like, but I'm still holding.
Well, you create the paradox, and that is to accept it without it changing me.
There you go. Can you tolerate it?
Oh, I can let it flow through. Yeah, thank you very much. I can honor what you're saying to me, and I can move it into the third person and do fine. Thank you very much.
Yeah.
And Stephen, there's going to be another wave, I'm afraid, coming from me right now. And that is, I've had the great privilege of knowing you, I think must be at least 15 years now, having worked with you at various conferences and workshops and things like that. And I just want to thank, not only have you given us an understanding as to how we can make the world a better place and how we can support people's health and well-being. So not only for what you do am I so deeply grateful, but also for can I say, what you are and who you are. And it is really always, I've seen over the years, all the time that I've known you, your great authenticity and your great integrity. And I think that just comes over to us all. So for that, especially, I want to thank you for this evening, because I think you've given us not just a theory, but a flavor, a sense, a touch of what humanity truly is through your demonstration. So deep thanks for that, Stephen. And we really appreciate your time.
Well, thank you, Michael. I also want to thank you. I want to thank Gazelle, but I also want to thank many of the people within the body therapy work community, the somatic therapist community, because they were the ones that initially brought me in back actually in the 1980s, if you want to know that, through Peter Levine and through the Rolfing community. So I've been influenced and my eyes have been opened, and I've been asked questions that I had to think about and understand. And I've learned, what I really want to say is that it's been a bi-directional journey. And I have learned so much from attending your meetings, other meetings. And I go to the meetings and I don't just give talks, and you know that part. I'm there and I learn from the other people. And it's been extraordinarily helpful in developing a language and a presence that can communicate across disciplines. And remember, what is the goal? The goal is to disseminate ideas. And what is the frustration that many of us have had in our lives? And as we haven't had the opportunity or the language to communicate what we knew was inside of us. And I feel that's just term bless, another word I never use, but really bless, but really for the true sense of gratitude that the ideas are welcomed and they're being explored, and I am learning from you and others.
Deep appreciation. Stephen, it's so rich. We're going to get a recording off to everybody who's registered, all our participants. So my own sense is that I'm going to have to watch this a number of times to digest each of the little nuggets that have come through.
Also, send me an email and I'll send some supporting articles which you can disseminate.
We will be really happy. We've had a few requests for that. Yeah. So thank you so much, Stephen. We will do that. So that will come in the next few days.
And when I do, before I say goodbye, I want to tell you what's happening in a couple hours. My son, my daughter-in-law, and our 4.5, almost 5-year-old granddaughter is coming. And they will be dominating all the activity in this house for the next 3 days.
Well, thank you for your generosity in preceding that with spending this time with us, because I think everyone has deeply appreciated it. Enjoy your family and very best.
Thank you for the wonderful interactions, and I hope to see you in person soon.
Thank you, Stephen. We look forward to that.
I'm going to sign off. Thank you. Bye-bye.
Bye, everybody. Lovely to meet you.